Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Thanks for listening to Behind the Knife. This is Jason here. If you're prepping for the complex general surgical oncology boards or just looking to level up your surg-onc game, you need to check out our surgical oncology board review. This isn't some lame review with just flashcards and outlines. We've created comprehensive, high-yield scenarios covering the most tested diseases, plus expert commentary and updated guidelines that actually stick and are proven to help you pass the boards. Breast, pancreas, sarcoma, you name it, we've got you covered. Available on our app, so you can review anytime, anywhere. Group discounts are available. Enjoy the episode and dominate the day.
Hi, everyone, and welcome back to another episode with your Behind the Knife surgical oncology team. So this is the start of a new BTK surgical oncology season, and we're excited to have two new members to the team, and I'll let them introduce themselves. Unfortunately, Connor's unable to join us this season, but we wish him the best of luck as he starts his time as a staff. Let's start with introductions, and then we'll kick off our case for today on Pheochromocytomas.
Hi, everyone. I'm Joe Broderick. I am in my research year at Brooke Army Medical Center. I am between my second and third year of training.
I'm Galen Gist. I'm also in between my second and third year of training, currently in my research year as well.
Hi, I'm Elizabeth Barbera. You guys know me from last season. I'm a general surgeon now in the UK, but I plan on applying to surgical oncology in a couple of years.
Hi, I'm Lexy Adams. I'm a fellow at MD Anderson.
I'm Tim Vreeland. I'm a staff surgical oncologist at Brooke Army Medical Center.
And then we have one other staff surgical oncologist, Dr. Daniel Nelson, who unfortunately won't be able to join us today, but we look forward to hearing from him in future episodes. Okay, let's get started. Galen, you're seeing a 40-year-old man referred for an incidental left adrenal mass found on CT during a workup for kidney stones. You have in the referral that he has also been complaining of episodic headaches and diaphoresis, but no other information. What else do you want to know from the history and physical exam?
I'd start by asking about symptoms that you may have from a mass in each part of the adrenal gland. For example, I'd ask about symptoms of cortisol excess, aldosterone excessive sex hormone production. More specifically, for him, I would ask about catecholamine excess. Things like episodic headaches, palpitations, diaphoresis, flushing, anxiety, tremors, orthostasis. I would specifically ask about any personal family history of pheochromocytomas, adrenalectomies, or cancers, endocrine or otherwise, or family history of endocrine symptoms, specifically MENA2, von Hippel-Lindau, or NF1. On exam, I would look for hypertension, orthostatic changes, or a palpable abdominal mass.
Okay, great. He endorses episodic diaphoresis when he is sitting and watching TV, and he feels like his heart flutters during these episodes. He also reports a new tremor and increasing anxiety. On physical exam, his vitals are significant for a blood pressure of 187/92 with a heart rate of 102. And he is anxious appearing with a subtle tremor. He has no palpable abdominal masses and no signs or symptoms of cortical adrenal hormone excess. How are you going to begin your work?
I'd start by ordering plasma-free fractionated metanephrines and normetanephrines, as well as a confirmatory 24-hour urine for fractionated metanephrines and normetanephrines. If I didn't already have it, I would order an adrenal protocol CT. And then lastly, as symptoms of a pheochromocytoma can often be nonspecific, I'd order a CBC, CMP, TSH, urinalysis, and drug screen. I'd also consider sending workups for Cushing's and hyperaldosteronism, depending on my degree of suspicion.
Yeah, I think that's all good. I think one thing that everybody's always confused by is which metanephrine to order. On the ab site, they'll ask, which is the best test, which is always a very confusing question. But in reality, you always check plasma first. And if the plasma is high and you have a high suspicion, your diagnosis is essentially sealed, so there's no reason to get urine. If the results of the plasma test are equivocal or you're not sure, then you would get the 24-hour urine test. But it's actually pretty rarely needed in real life. And if patients hate it, they have to carry around a jug and collect all their urine for 24 hours. So that's why the plasma test really is the first test of choice. It's just simpler, it's easy to get, but it can have lower sensitivity and specificity than a urine test. And when I'm talking about this in a lecture, I always draw the area under the curve. The plasma metanephrine can peak during times of stress, whereas the 24-hour urine test is going to capture all those peaks and valleys all in one test over 24 hours. That's why it is a better test in the sense that it's more sensitive and specific, and particularly specific because the plasma may peak just from a time of stress, or some people report even just from being stressed out by seeing the needle of having a blood draw that can bump your plasma metanephrine up. The rest of that workup all sounded very reasonable. On an ab site, you get this history of episodic sweating and palpitation. You know what it is. Just make sure you get the plasma metanephrine before you do anything funny like trying to biopsy or doing surgery.
Thanks, Dr. Vreeland. Yeah, that all makes sense. And in this case, we did end up getting plasma-free fractionated metanephrines and normetanephrines, as well as the 24-hour urine for fractionated metanephrines, normetanephrines, which were all found to be significantly elevated. And then our CT demonstrated a highly attenuated 4-centimeter left adrenal mass. So now that we're underway, let's review some background information on pheochromocytomas. Galen, you can take it from here.
Yeah, so pheochromocytomas are a rare neuroendocrine tumor arising from the chromaffin cells of the adrenal medulla. So normally these chromaffin cells contain storage vesicles of norepinephrine and epinephrine. Thus, it's no surprise that these tumors are all in the classic presentation that we think of for pheochromocytoma. They compromise about 0.05 to 0.1 of all hypertensive patients, with the annual incidence in the United States of about 500 to 1,500 cases. The peak incidence around 30 to 50 years old. Joe, do you remember the rules of 10?
Yes, though it's not entirely accurate. 10% are bilateral, 10% are extra-adrenal, 10% are malignant, 10% occurred children, and 10% are familial. As a pediatric surgery tie-in, up to 30% of tumors in children can be extra-adrenal. That's compared to 10% in adults.
Just one real quick thing on the rule of 10s. That only applies to sporadic pheos. So familial pheos are ones that are genetically driven. Those rules go out of the window. They're much more commonly bilateral. The rule of 10 is only for sporadic pheos.
Awesome. Thank you, Dr. Vreeland. One important update to this well-taught rule is that over 40% are associated with germline mutations such as MEN2, von Hippel-Lindau, NF1, succinate dehydrogenase deficiency, or a number of other susceptibility genes not related to those syndromes. So genetic testing is crucial, especially in younger patients. Beth, can you tell us more about the workup for these patients?
Yeah, definitely. So we talked about this a second ago, but just to drive the point home, a key part of the discussion is that plasma-free fractionated metanephrines are a screening tool. They have a 99% sensitivity, but their specificity is lower, about 85%. And it can also be affected by a number of medications. So medications like Tylenol even, some blood pressure medications, TCAs to name a few. So the confirmatory 24-hour urine testing has a 99% specificity, just like Dr. Vreeland said. Elevations that are 3 times above the upper limit of normal are diagnostic. Also, we mentioned this a second ago as well, but if there's any uncertainty about the diagnosis of a pheo, you definitely should get lab testing before you biopsy because manipulation of the tumor increases the risk of a catecholamine surge. Lexy, can you talk to us about the imaging findings typical for pheos?
Yes, Beth. So when you know you have an adrenal mass, you ideally get an adrenal protocol CT, which is a multi-phase CT with very thin cuts through the adrenal gland. And for those, you'll typically see a mass that's greater than 3 centimeters, greater than 10 Hounsfield units. You could also consider getting an adrenal protocol MRI. These masses will be characteristically bright on T2 phase.
So just to give a little more practical and clinical perspective. So when I think about imaging an adrenal gland, I'm thinking about, is this a benign adenoma or is it everything else, right? So there are these imaging characteristics of ACC, a pheo, and a MET, but really they're not very good and they're not going to actually help you differentiate those. So really what you're trying to figure out is, does this have characteristics of a benign adenoma or is it one of everything else, right? And then once you get your elevated plasma metanephrine, who cares what it looks like? It's a pheo, right? So if it doesn't look like a fatty adenoma, and it's, again, you talked about the higher Hounsfield units, the brighter on T2 on MRI, those are the things that tell you it's not a benign adenoma. And then you got an elevated plasma metanephrine. So now really you're just thinking, is it on the left or on the right? And if you have a mass on one side and a high plasma metanephrine, go after that one is the bottom line. Don't get too excited about the imaging characteristics. The one weird thing about Pheos is that because they're biochemically active, they will show up on an MIBG scan. And the newest thing is on dotatate. So if you can't see it on a regular CT, but you still have a very high suspicion of Pheo and you're trying to find it, the old answer was a MIBG. The newer is a dotatate PET scan, which is typically done for neuroendocrine tumors, but these will also light up on that.
Okay, thanks, Dr. Vreeland. All right, let's get back to our case. So to summarize, we have a 40-year-old gentleman who presented with signs and symptoms concerning for pheochromocytoma. He has elevated plasma and urine fractionated metanephrines, and he has a 4-centimeter left adrenal mass. So we perform genetic counseling, recommend multi-gene testing for hereditary endocrine neoplasia syndromes, which are otherwise unremarkable.
Just a quick comment on that. Why do you have to get genetic testing before you go to the operating room? What are you going to do differently if they have a mutation versus if they don't? Let's say turns out they have a MEN syndrome and a Pheo. What are you going to do different?
You might be concerned about our bilateral pheochromocytomas or extra adrenal pheochromocytomas, depending on the mutation.
Yeah, so mostly bilateral. It's not that you're concerned that they necessarily have bilateral right now, but particularly in a young patient and a 16-year-old with a Pheo who has a MEN syndrome, you're very concerned that they're going to develop a contralateral Pheo at some point in their life. And that would be the role for what's called a cortical sparing adrenalectomy, right? Where you intentionally take the tumor and the adrenal medulla, but you try to leave some cortex behind in case you then have to go and attack the other side later in life. So that's why it's important, especially in young patients, as you guys mentioned. But the indication is now for every patient with a Pheo, you should get genetic testing. But it's particularly important in the young patient because it may actually change the surgery that you do.
Thanks again, Dr. Vreeland. All right, Beth. So what are some of the other things you'd consider when planning an operative intervention on this patient?
Yeah, so I think it's very important to discuss preoperative management for these patients because surgical resection of a Pheo can result in labile blood pressure, arrhythmias, and tachycardia in the perioperative period. Intraoperatively, patients undergoing surgical resection can have arrhythmias, volatile blood pressure, and postoperative complications like MI, stroke, or pulmonary edema. So hopefully I've painted a good picture that multidisciplinary preparation for surgery to optimize the patient is crucial. So Lexy, can you tell us about the preoperative pharmacologic blockade?
Yes, and just a quick plug, there's a great Behind the Knife Surgical Oncology Board Review episode on adrenal masses that discusses all of this as well. But most sources recommend alpha receptor blockade, such as doxorubicin, 2 milligrams daily. You can titrate that up for a period of 2 weeks preoperatively. Your goal is to get their systolic blood pressure below 120, and ideally even some mild orthostasis, or people describe slightly runny nose. They should also be counseled to hydrate sufficiently preoperatively because they potentially might bottom out a bit when the mass comes out. If the patient remains tachycardic after a period of 3 to 4 days, you can add a beta blocker like metoprolol and titrate that up. Phenoxybenzamine is the one we all remember from medical school and the traditional test answer. That's typically no longer used. It's pretty costly and it has some bad side effects and is honestly hard to find.
I think it's always preferable to understand rather than memorize. So why do we use this new alpha blockade agent? Cardura is the one that everybody uses pre-op. And the reason is because it's a selective alpha blocker. So going back to like medical school and understanding all the alpha 1, alpha 2, if you block alpha 1 is negative feedback on your sympathetic drive. So if you block alpha 2, you turn up the sympathetic drive, which is exactly what you don't want to do in these patients. Now, if you're using a non-selective alpha blocker and blocking alpha 1 and alpha 2, you will lower their blood pressure with the alpha 1, but then turn up their sympathetic drive with the alpha 2 blockade, and you end up causing worsening tachycardia. So that's why we don't use that non-selective alpha blockade anymore. We use selective alpha blockade where we're blocking alpha 1, but we're intentionally not blocking alpha 2. So that's why now we don't use phenoxybenzamine, because now they're selective alpha blockers. Because of that, the traditional teaching about like alpha blocker, then beta blocker, you often don't need a beta blocker anymore because we're not causing this reflex tachycardia. So you alpha block to orthostasis, which you guys mentioned, and then a lot of people use rhinorrhea as a marker of effective alpha 1 blockade as well. And then you see whether or not they need a beta blocker, which most patients will not if they don't have that reflex tachycardia.
Okay, thanks everybody. So let's talk about our operative approach now. There's multiple considerations to talk about when we talk about the surgical approach to pheochromocytomas: MIS versus open, transabdominal versus retroperitoneoscopic, as well as cortical sparing, which we brought up earlier, or total adrenalectomy. So let's start with our plans for this patient. Again, we have a patient with a 4-centimeter left adrenal mass and no evidence of other lesions. Lexy, what are your thoughts?
So there are several approaches you can take to perform an adrenalectomy, but in this case, I would perform a laparoscopic posterior retroperitoneoscopic adrenalectomy.
Okay, great. So while ultimately the surgeon should do the procedure they're most comfortable with, NCCN guidelines do recommend usually a minimally invasive approach when feasible. The whole concern with an MIS approach for a patient with a malignancy is concern for capsule rupture and malignant dissemination, or a non-R0 resection. Times that you may consider an open approach are when the tumor is large, so potentially greater than 6 centimeters, or some surgeons' cutoffs, and therefore higher risk for rupture or difficult removal. When there are invasive features, or if you're considering potentially a lymphadenectomy at the time of surgery. Also, if the patient has high-risk mutations, such as SDHB, which is known to have a higher likelihood of extra adrenal involvement, you may consider an open approach instead. There's no official recommendations for a retroperitoneoscopic or a transabdominal approach. There's some retrospective data, but ultimately familiarity with the approach is key for performing this operation safely, so you should do it how you feel that you can most comfortably resect the lesion. Lexy, how would you go about performing this operation?
I would place the patient in a prone jackknife position. I would palpate the tip of the 12th rib, make a transverse incision below that, pop through the fascia, develop the retroperitoneal space, and place my additional trocars. I would dissect through the areal retroperitoneal tissue and Giroux fascia to identify the superior border of the kidney. And then ultimately, I would mobilize that medial and inferior border to identify the adrenal vein, control that prior to doing any significant tissue manipulation to prevent significant hormone release. Finish mobilizing it with my energy device of whatever choosing, and then extract the specimen. But there are many other ways to also do an adrenalectomy. Beth, how would you do a transabdominal approach?
So after port placement, I'd mobilize the splenic flexure of the colon from the lateral inflection down to the inferior pole of the spleen. I'd divide the splenorenal ligament. I'd develop a plane between the tail of the pancreas and the kidney. We know that the adrenal gland is located in the perinephric fat at the superior pole of the kidney. I'd dissect along the inferior medial border, expose the adrenal vein, which I'd clip and divide. I'd take the smaller arterial vessels with a cautery device and clear any remaining attachments to free up the specimen. Again, throughout the dissection, it's super important we're taking care to avoid manipulation of the adrenal gland. Not only is it friable in general, but any excessive traction, pressure, manipulation can lead to that catecholamine surge we're trying to avoid.
Yeah, you're talking about the left there because you're talking about splenic flexure. Obviously, there's a right as well. The right's pretty easy. You just kind of lift the liver up and there's the adrenal gland. On the left, the other thing that's described is sometimes people do not split the splenorenal ligament. They just roll the spleen, pancreas, and colon together all over together. And that is a little bit simpler in some ways. You have to mobilize things quite a bit and slip the pancreas over on itself to get all that stuff out of the left upper quadrant. But it does simplify a bit because you're not wasting, particularly on the robot, you're not wasting an arm to hold the pancreas up out of the way. You just roll everything over. And that the stuff about manipulation is obviously important until you take the vein. Once you take the vein, then you can manipulate the adrenal gland. What you don't want to do is rupture the tumor. And particularly with the robot, I think that's important because the robot, you don't have tactile sense and the robot is very strong. So you want to try not to touch the tumor with a bipolar or something that could potentially dig into the capsule of the tumor. So you want to try to grab the gland or grab the sat around the gland, and even the gland can rip when you are manipulating the adrenal gland, just so that you don't accidentally poke into the tumor with your robotic instrument. All right, Beth, what about open? Why would you do open and how would you do it?
Like we said earlier, you might consider that in patients with large tumors, potentially above 6 centimeters, though again, different societies and institutions have their own cutoffs. You may consider it with signs of invasion or tumor mutations, resulting in a higher risk of malignancy. And so that's when an open approach is traditionally recommended. This can be approached through a subcostal, midline, or Makuchi incision. I'd also like to highlight some differences with the right adrenalectomy here as well. So in an open approach, this requires mobilization of the right lobe of the liver and exposure of the retrohepatic IVC to identify the adrenal vein and gland. Remember, the right adrenal vein is shorter and it drains directly into the IVC. This makes it easier to tear, and so you really want to be careful and not manipulating and avulsing that, as then this may potentially retract and cause bleeding that's difficult to control. Dr. Vreeland, do you have a size cutoff for when you might pursue an open approach, or any other thoughts on right versus left?
Yeah, I don't think there's a specific size cutoff, but it's probably more like 10 centimeters than 6. I think 6 you can handle MIS pretty easily, but part of the reason that these really big tumors are a problem is exactly what I was talking about earlier. Trying to manipulate a 10 centimeter giant tumor with a robotic arm without poking into it can become difficult. And the other thing is that, particularly on the right, that adrenal vein usually comes off of the back of the IDC, and the tumor, when they're that big, it'll push the IDC and liver anterior. So you're almost having to kind of reach around the back of the vena cava to get control of that vein. MIS can be really difficult, and you're really pushing on the tumor. Whereas, granted, it's an incision and everybody wants to do everything MIS, but you're just going to be better at manipulating the tumor safely with your hand than you are with an instrument. And so when you have a really big tumor that you got to pull out of the retroperitoneum to be able to get stretch on that vein to control it, sometimes having your hands in there is just safer. And when it's really big, I don't know what that cutoff is, somewhere around 9 or 10 centimeters, then I'll probably convert to an open. And unfortunately, I do think that having inverted L or modified Makuchi on the right, or a L-shaped incision on the left, does help in some ways to get that exposure. So it just depends. If they're thin and you think you can stretch them to get over there with a midline, that's totally fine. But if it's really big, 15, 20 centimeters, then having that transverse portion of the incision allows you to safely get around it, and that's okay to do.
Great. And then we also should mention the cortical sparing approach. Dr. Vreeland brought it up earlier, but this is a good approach to consider when you have patients with bilateral pheochromocytomas, or if they've had a previous adrenalectomy, and also if they are an MEN2 patient. There's an interesting retrospective study of 562 patients with MEN2 and pheochromocytomas. This was multi-center across 30 centers on 3 continents. And they found that adrenal sparing resections led to similar rates of recurrence with lower rates of adrenal insufficiency and steroid dependency. This was a pretty impressive reduction of only 43% of patients versus 86%. And there was no difference in pheochromocytoma-related overall survival. And of course, more studies are needed. This was just a big retrospective study, but ultimately it's good to consider a cortical sparing approach. So once you've exposed the adrenal gland, like we've previously described, you can do an intraoperative ultrasound to identify the tumor. You want to look at its relationship to the adrenal vein and make sure there aren't any other nodules. If it's a single mass, you can enucleate it with an energy device. And then ideally, you preserve the adrenal vein when you're doing a cortical sparing adrenalectomy so that you preserve the function of the remnant. If you suspect there's going to be less than 30% of the gland left, then you probably should just perform a total, because the remnant is likely to be non-functional at that point.
The only other thing I'll talk about for surgical management is really not in your hands, but just make sure your anesthesia team that day have pressors, beta blockers, and fluid all ready to go. And they have to be able to deal with the ups and downs, because inevitably you may manipulate the tumor a little bit at the beginning. And then once you clip the vein, they can have a profound kind of drop off in their catecholamines and require pressure support. I think it's just important that you have a good anesthesia team. And one of my attendings in fellowship said, if you come in and they're inducing and it's already looking like a rocky road, you should probably cancel the case for that day and get a better anesthesia team the next time. So if they can't handle induction, they're probably not going to do well throughout the operation.
Perfect. Joe, can you touch on the postoperative management for these adrenalectomy patients?
Yeah, definitely. For patients with an uneventful intraoperative course and minimal hemodynamic instability, admission to the floor is acceptable. For patients with ongoing hemodynamic instability, monitored bed with telemetry or ICU may be required. These patients are at risk for hypotension and hypoglycemia in the immediate postoperative period. Hypotension, likely due to residual preoperative alpha blockage, hypovolemia, or intraoperative blood loss. And hypoglycemia, although relatively rare, can occur due to preoperative insulin resistance from the elevated catecholamine levels, suppressing alpha and beta cell function. Most patients who have had an MIS adrenalectomy are often able to go home within 24 hours unless they need ongoing blood pressure or hormonal management.
Awesome. Thanks, Joe. Okay, let's talk a little bit about surveillance. So currently the NCCN guidelines recommend history and physical, and then plasma-free or 24-hour urine metanephrines, norepinephrines between 3 and 12 months, followed by every 6 to 12 months for the first 3 years, and then annually for up to 10 years. For imaging, a chest CT or MRI abdomen pelvis is only recommended as clinically indicated. So if you're concerned for recurrence or metastasis, then you would order those in. After 10 years, surveillance is recommended just as clinically indicated.
Thanks, Galen. Lastly, let's briefly discuss pheochromocytomas presenting with concerns for metastasis.
Yeah, so for patients, they have a concern for metastasis. Those would be patients with large tumors, signs of invasion, or high-risk mutations. And for those patients, you want to do a complete workup. So that's going to include chest CT, an adotate PET CT, or an FDG PET CT. And all of this in order to identify and quantify the extent of their disease. Patients will be discussing multidisciplinary tumor board in order to identify targeted therapies and treatment options. So these may include chemotherapy, radiation, a cytoreductive resection when possible, somatostatin analogs for those with tumors expressing somatostatin receptors, and even peptide receptor radionucleotide therapies such as Lutathera.
The only other thing to mention, there is medical therapy for pheos that are unresectable, so you can give a false tyrosine analog, met-tyrosine, and that will basically biochemically decrease catecholamine production across the body to include in a pheo, and so that can reduce symptoms, but it won't prevent the tumor from progressing.
Thanks, Dr. Vreeland. Let's do a quick summary of our episode before we sign off. Pheochromocytomas are rare neuroendocrine catecholamine-secreting tumors arising from chromatin cells of the adrenal medulla. Patients present with symptoms of catecholamine excess, and workup should include plasma-free fractionated metanephrines with confirmatory 24-hour urine metanephrines as indicated, as well as cross-sectional abdominal imaging to include an adrenal protocol CT. Prior to operative intervention, patients require pharmacological blockade with alpha receptor blockers like doxazosin and beta blockers like metoprolol as indicated, starting 2 weeks preoperatively. Minimally invasive approaches for resection are preferred. However, open approaches should be considered in the setting of large tumors or those with invasive features. Additional considerations for cortical-sparing procedures is warranted in the setting of bilateral disease or hereditary syndromes. Postoperatively, patients require serial histories and physical exams, as well as plasma-free or 24-hour urine fractionated metanephrines and norepinephrines. That's it for this episode. Thank you so much for joining us on Behind the Knife Surgical Oncology. Dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.